Well, good evening, everyone, and thank you for being here. I'm very excited for this discussion. I think it's a very important one and really looking forward to diving right in. We're living in a very exciting time in health now and starting to finally take advantage of new insights in genetics, stem cell science, and gene therapies to really lead to breakthrough treatments. But it's a bit of a double-edged sword. On the one hand, you have the innovative therapies, and on the other, as we all know, there are still basic health needs that are still unmet. So, Andy, I'd like to start with you. One of the important consequences of having all of these innovations, it's a benefit, is that we're seeing people who are living as survivors with their illness, and that's especially true in your area of blood cancers. And you've said that blood cancer is one of the greatest success stories in the cancer research world. And that's certainly true. We see stem cell therapies, gene therapies often successful first in treating blood cancers. Why is that?
Yeah, and you can go back to 1949 when first patients were treated with chemotherapy. The first responses that we saw were in blood cancers. Precision medicine started with chronic myelogenous leukemia, a blood cancer, immunotherapy in lymphomas, cellular therapies, CAR T-cell therapies started in leukemias and lymphomas as well. And it's the proximity of the cancer cells to the immune system in the bone marrow. That's where they start. So they are uniquely vulnerable to the tissues in which they arise, and it's also the availability of the cells. It's a lot easier to draw blood or do a bone marrow test than it is to biopsy a brain or a lung. So we have been able to learn a lot about the genetic and molecular underpinnings of the diseases and target them with precision therapy. We've been able to learn a lot about the molecules that exist on the surface of the cells, so we can go after them with immunotherapies. And it's remarkable to see as well, because when we target the immune system, the malignant side of the immune system, we're also learning how to target the normal immune system. Medicines that are used for precision medicine and CML are used for non-malignant diseases. We see immunotherapies now being used for lupus, for other autoimmune diseases. And it's really a remarkable progress. It is a proving ground for new therapies.
And Selma, you've witnessed experienced firsthand the benefits of this with the stem cell therapy that you described in your moving documentary, Introducing Selma Blair. So I'd like to play a clip for everyone first.
Great.
Very dramatic, I said. So let's start with the very basic question. How are you doing?
I'm doing really well. I've been relapse-free for a couple years. I did, I was diagnosed with multiple sclerosis in 2018. I most likely had it since 1979 was my first optical neuritis. So it was a long time coming for that diagnosis. And I was really sickly for so long that I was actually so relieved to get any diagnosis. I was like, oh my God, receipts, legit, I can't believe it. Because I just did feel it was psychosomatic. So to be helped, to even think, I made a real commitment when I was eligible to have a bone marrow transplant to try and halt the progression, because it was a very, very aggressive form of multiple sclerosis, and I do believe that halted my progression a lot. Ultimately, I did relapse after that and had to find another treatment, but it bought me a lot of time and an attitude shift I really needed. But I am someone that felt very good on chemo, which is funny, is like immediately my dystonia had gone away. Like it took down some inflammation or something. I don't know the exact mechanics, but I was grateful to be able to be given like a big boost.
In that clip, you said something I think very powerful, which is that you're uncomfortable with permanent sickness. And we're here to talk about really how medicine is changing that and hopefully helping more people to avoid that. Are the benefits that Andy just described and some of the advances that we're seeing, as a patient, are you feeling that? Are you seeing those trickle down to patients? Are you seeing that difference? Do you think it would have made a difference if you had been diagnosed, let's say, a decade earlier?
Exactly. That's the thing. When I did tell my mother, who was dying by the time I was diagnosed, and I said, I have MS, and she said, oh, that's amazing. They have so many things for that now. And I didn't feel afraid. I had just been so tired for so long. And just to have, the way my damage had just been a long time accruing. So, it was a pretty strange thing to walk around so symptomatic off and on, and things I didn't understand about neurology and immune system and nervous system that I understand a little better. But yes, I do feel it. It's exciting. It was exciting for me to be able to be a part of that and be around other people with lupus, and even, the work they were doing in ALS, just to have anything that really had hope that someone could start sinking into. And it's so amazing that there's such such old treatments, and to think that they can, be used in ways that are so different than what I thought. I was that person that was like, oh God, if I need chemo, I have cancer, we're just gonna hang it up because I'm a complainer. It's not gonna, that's it. Like, I don't want it, I don't want it. And then to elect and to fight for that treatment was a very funny experience. But it was a good experience to have all that time to work on the healing with it.
Okay, I want to come back to that experience, but Andrew, as more people are living with illness as survivors and relying on longer-term treatments, how can something like Amazon's One Medical, what role can that system, that structure play in preventive care, in helping people to stay healthy versus only treating them when they're symptomatic?
Well, first of all, thanks for the opportunity to be here. Thank you especially for your willingness to share your experience. Amazon One Medical is first and foremost a medical practice. It's a primary care practice that was established to address a lot of the issues that the prior panelists were discussing, issues of burnout in primary care in particular, but also issues of just the availability of healthcare, the accessibility of healthcare to the people who need it the most. And the concept that One Medical started with initially, that is just intrinsic to primary care in general, that is nearest to my heart, is the idea of longitudinal care, being able to take care of people over the course of their entire lives. Not just with a focus on prevention, but with a focus really on just the entirety of the life experience. Because even with the best preventive measures, illnesses do happen. Chronic illnesses do arise. And we don't want to have that be the moment that the patient who we've been taking care of for years upon years upon years has to exit this system and go to a different system and get highly compartmentalized care over there from someone who doesn't necessarily know everything that they've been going through in every other facet of their lives, in which case that care might be compromised. But what we try to do in primary care is have a very holistic approach to dealing with each patient, addressing all of the medical conditions, all of the preventive questions in the context of all of the acute questions and the chronic questions about disease states. So, because everything's interrelated, no matter how much we might try to categorize things in our scientific reductionist approach, ultimately we are all, holistic organisms, and the diseases don't necessarily know whether, what the names of the diseases are, right? They absolutely don't. So we are always trying to approach these things holistically, where I think One Medical and Amazon One Medical will be especially important in the future is helping people get care for their chronic conditions outside of specialists' offices. Ultimately, given that the medical workforce is currently, unfortunately, shrinking, for a lot of reasons, it's very important from the perspective of primary care to make sure that specialists are able to focus on the patients who are in the most acute need of care, and that where you would like us to decant specialists, like that's maybe a bit of a technical term, but help bring patients out of those specialty clinics and back into primary care, where with the assistance of AI and through great relationships with large academic medical centers, practices like Amazon One Medical can really bring those patients back into the primary care setting for their ongoing healthcare needs.
Just quick show of hands here. How many people rely on One Medical or something like it for primary care services?
As a couple.
Yeah, see, that's the problem, right? That's the problem with the U.S. healthcare system right now. And, you know, from personal experience, too, with my parents, I think they've changed primary care physicians like once every 6 months over the past few years. It's just a reality. And this is at like a major, in a pretty big city at a major, you know, academic center. So tell me, you've been with One Medical from the beginning. And as you said, from that initial vision of providing primary care services and really trying to, you know, take the burden off of the healthcare system where it can be taken off, and really focus the healthcare system, tertiary care centers, on the acute care. How has that changed? Like, how is that balance getting better? Are you getting more successful? What are some of the strategies that are helping you to really concentrate primary care at systems like One Medical and to really make that difference?
Well, it really starts by making things easier for the patients. And that's why ultimately the acquisition of One Medical by Amazon, from my point of view, made a lot of sense, because Amazon is so customer obsessed. And you know, think what you will about whether patients are customers or patients, but ultimately we are people who have needs, and One Medical set out to make it easier to get those needs addressed. Have appointments that are available the same or the next day. Let the appointments be a little bit longer so you can really download the entirety of what's bothering you. Be available digitally. Have a team that's available 24/7 inside of our app. Just increasing the ease with which patients can access healthcare was fundamentally the major strategic initiative at One Medical. The other thing that we really set out to do in those early days was to make it easier for the clinicians as well. Try to absorb more of those administrative tasks that we heard about in the prior panel, get those to other team members who can do them on behalf of the primary care clinicians, and ultimately offload more and more and more of that to technology, which is something we're all extremely excited about. We also have to work very carefully with large academic medical centers and other large health systems to build great partnerships there, so that when our patients do need access to specialty care, they can get it. And we have to work thoughtfully with payers, including with CMS, to make sure that their needs are met too. And another really important element of what primary care does when it's going well is reduce total costs. A lot of healthcare, I mean, I don't have to tell you all, but maybe 20-25% of what we currently spend on healthcare could have actually been avoided altogether if patients had gotten timely, appropriate care in a primary care setting, whether that was virtually in the middle of the night or in a doctor's office. If you'd gotten the question answered, you wouldn't have ended up in an ER or a hospital. So that's another important element of what we're doing.
I'm glad you brought up cost, because that's obviously another huge issue in healthcare right now. Andy, one of the, almost by definition, innovative breakthrough therapies are often expensive, and especially when we're looking at bespoke and, you know, custom tailored gene therapies. How are we able to change the financial incentive structure now in the US to kind of incentivize maybe higher upfront costs for something that potentially could be curative, you know, for someone like Selma, versus like a lifetime of going in and out of the hospital, treatments that may or may not work? Are we making any progress on that?
No. No. So, yeah. So as cost of care, as we advance and develop more and better therapies, cost and complexity of care is increasing. So cost of care is what the payer paying. Complexity of care is what the household is paying, right? Whether it's travel, parking, whatever, lost salary, lost wages, whatever it might be. You know, we see that we did a study at Blood Cancer United a year ago, and it showed that nearly half of patients who are diagnosed with cancer will burn through their entire life savings within 2 years. Curative therapy is leaving families with generational debt, and I think we need to change the conversation. We need to think. I was speaking to Aaron Zamet Ruddy over there, who was diagnosed with chronic myelogenous leukemia in 2001. One of the very first patients ever treated with Gleevec. And she needed Gleevec for most of the last 25 years, except when she had her 3 children. You know, we think about that is 6 figures and up a year of cost. But think of all the moments, having 3 children during that time period, having the ability to experience that family, the ability to give rise to and raise the next generation. We talk about cost in the terms of our annual budget cycle. We need to think about the other side of the balance sheet, which is the years of life that are saved. The years of life, whether you measure that in anniversaries and birthdays and beautiful family moments, or you measure that in hours worked or contribution to the GDP, we need to be thinking about the benefit of preservation of life, because cure in the cancer world often means lifelong treatment. Or it means a definitive therapy, like CAR T-cell therapy. You mentioned genetically modified T-cells. It's amazing what we can do in the lab and what we can bring to the clinic, where we can train our T-cells, genetically modify our T-cells to go after a lupus or an MS clone, or to go after a malignant cell. But that's $500,000 to $1 million a pop. And though CAR T-cell is approved for leukemia and lymphoma in the United States, only about 1 in 4 patients access that therapy. This is curative therapy. This is therapy where they are done treatment, but it's complex. They have to travel to a major medical center, and it's costly. So they may be underinsured, they may be inadequately insured. A 5% copay on a $1 million product is just not feasible for many families. So we need to think less about the cost of the therapy and think more about the benefit, the dividends that therapy will yield with years of life gained.
Selma, you were nodding as Andy was talking about the cost. So,
It was, the thing, yes, I'm glad I probably wasn't diagnosed in 1979, because I might have been told, like other people, like, okay, that's it, like kind of a give up vibe, and that changes a lot. My attitude really saved me, but the cost for treatment, even for a beautiful, rich, and famous woman like me, just kidding, but it was really brutal dealing with insurance. It was really brutal until I found avenues and helplines and so much red tape to get the medicine the only one I needed, the thing I needed, and it was, I was really lucky that insurance did pay for the big, all of it ultimately, but now, I hear, it's the thing I hear, it breaks people's heart. My mother went through everything, just, living her life in her apartment, dealing with a, disease, like it's just life. And death is very costly to keep living. But it's really hard. And also, if I would have just gotten an MRI in the first place, I would have saved a lot of doctor's appointments. I'm just saying. I'm a real big fan of that diagnostic tool.
well, I think that very powerfully speaks to this,
But the money thing can wear you down so much.
Yeah.
And when you are already exhausted with a diagnosis, it does make you want to just, that's what I get the most from the people that had followed me or my thing. Like, that's great that you're so rich, you can do this, but I'm, and you just break because you're like, no, I went through it too. I just was able to keep fighting or find someone or an avenue to help me too, to find the right way for insurance to get on the ball for me. But it does. break my heart.
And for many, one of those avenues is finding a clinical trial, right? Like a study, because there you can have access to something that's innovative. No guarantees, obviously, about the results or the effectiveness, but it's hope. Tell us a little bit about your journey and experience with that, and how can we improve that to help more patients find those trials, the right ones for them.
I don't know. I mean, I really don't.
I thought you were going to
because
solve
it's
this problem
so-
for us.
I wish. I don't know. I didn't have. I mean, I wasn't even aware that I was in a trial. I think. Like, you're so out of it at the time. I was like, oh, that was a trial. Like, I don't know. I just want hope, and I did find a doctor that really, really could talk to me, that had the time, that had the patience, because I had so many things that didn't look a lot like MS. It just didn't present the way it typically presents anymore, other than the fatigue or foot drop. But I had developed these tics and dystonia. Anyhow, enough about me. I don't even remember what I was saying. I got off track. So sorry, but
The clinical trial.
yeah, thank you. I don't know, even as a patient that's doing really well now, and thank God I found the treatment that works for me now, and a doctor, and I feel confident if I do have a relapse, we're gonna come to, be able to help me with this same treatment I'm doing. I'm really confident right now, but in the beginning, I mean, it was, my entire life was searching for a cure of what ailed me and why I lost vision, and it came back. And doctors didn't take me seriously as a young girl. Also, I'm a really dramatic person and all this, and maybe I had a fog over it. But yeah, I wouldn't even know how to tell anyone how to do anything. I couldn't get a diagnosis for so many years because it's just, there's so many variables. And that's why I'm just a proponent of an MRI. Didn't have one for many years, not bitter or anything.
I wanna ask you, Andy and Andrew, about that. And as Selma's saying so powerfully, that it's a simple thing, right? And it could have made a huge difference, and we know it makes a difference for people. How do we finally, turn the boat around and with this healthcare system and focus on relatively simple, inexpensive
Because insurance didn't want to pay
things?
for an MRI for me,
That's,
like my entire
that's
life.
true. That's
you know,
true,
but
right?
it
So
was
cost
weird.
is one
You know,
thing,
it was
the
a strange
incentives
thing.
are the other. How do we finally prioritize prevention?
Well, certainly the folks who are paying for healthcare would like to have to spend less on it. So employers are certainly proponents of preventive care, and big payers are proponents of preventive care. We need
At the
to
same
move.
time, there's a lot of disincentives, right? Because
Absolutely.
employers are saying,
Absolutely.
why should I pay for scans that will potentially prevent a cancer for an employee who may or may not be with me 5-10 years down the road if they do develop the cancer?
Right, they're in favor of cheap,
Right.
inexpensive preventive care. That's a fair point. But I think we can, well, I'm highly biased in saying so, but I think the solution has to be by building primary care that at scale can solve these problems. If we get to the right level of scale, and of course, what's very important at One Medical is the right level of loyalty. If you know that whether the patient might, a patient might change employers, it might change insurers, but they're going to keep their primary care provider. If that primary care clinician is incentivized in a value-based way, we do well when our patients stay healthy, so we want to invest in their preventive care. So moving towards more value-based care is important, certainly, but there's a lot that we can do to bring down the costs of preventive care, even in a fee-for-service world. And it starts with, well, let's try to save money on a lot of the just waste and redundancy in healthcare, but let's also bring new technologies to bear. We can get a lot, first of all, we can get to the diagnosis a lot more quickly today than we would have 10 or 20 years ago. Thanks to technology, thanks to the availability of, you can just ask questions of AI and it will serve up the diagnosis in many cases with much more accuracy than the human clinician could. But just even without that technology, having a primary care clinician or a clinician in general who has the time and the motivation to listen and to take you seriously, that makes a huge difference. So that can save a lot of money in the long run. And I'm sure that while MRIs will be vitally important for the long term, there are a lot of new diagnostic tools that are helping us get to diagnoses a lot easier right at the point of care, which will hopefully get, ultimately fewer people in line to get the MRI that the insurance companies don't want to pay for, so that it's really the right people who are getting the MRIs. So a lot that we can do through great primary care and through AI-assisted primary care and AI-assisted just self-diagnosis and self-care.
Andy, you agree with that? Just really quick. I know we're running short.
Yeah, and I think the other part is education. Yes, I agree with all of that. And one of the diseases, one of the blood cancers, multiple myeloma, it tends to present in among blacks and Hispanics and younger patients and male patients, and there are just so many examples of delayed diagnosis for a young male coming in with back pain. And not recognizing that is the sign of malignancy of a young woman, dramatic or not, coming in with multiple different symptoms and not getting an MRI. Yes, AI, absolutely, but it has to start as well with provider education from informed organizations that know what they're talking about.
Okay. And Selma, I want to give you the last word. When you look at where we are with MS treatment now, what gives you hope for the future?
Well, I'm doing pretty good. I mean, I have to say that I didn't think I'd be here at this point, that I would ever feel well enough and have the right energy to, last long days and still be okay and not put that in a flare or anything. Like, I can live a life and stay up all night with my kid and not be worried that I'm gonna have a flare for 4 years. I'm excited. I know even the little bit I did when I came out, the visibility, I saw how much people were hungry for that and how much the patient wanted to learn more. I wasn't aware of, I couldn't find that much on MS. It was either like you have a really extreme case of progressive MS, they'd show that. There wasn't a lot on like relapsing, remitting. So just information and, I'm on a treatment that works for me right now, so I have to say I'm happy that I'm relapse free. But I love these conversations. I love knowing that there's other diagnostic tools that we know. I mean, I have a doctor now that listens to me. I thought I did before, but they couldn't see that someone that was an athlete could have a neurological problem back in the day, because it didn't present all the time, because I have relapsing MS. But I'm excited about it. I think everyone should be hopeful, but I think thinking outside the box, like zebras, not horses, is a big thing for a lot of people. It never occurred to me for someone that was addicted to my PDR that I ever had MS. Like, it just never occurred to me, and I thought I was a real little Dr. Blair my whole life. So, I have faith in the real doctors.
Well, I want to thank all of our panelists, Andrew, Andy, and Selma, and let's keep the fight going.
Thank you.
Thank you.